Good evening, one and all. I'm Dr. Saba Memon. I'm an associate professor at the Department of Endocrinology at KEM Hospital. And my talk for today will deal with adrenal Cushing spectrum across the lifespan. I would like to thank the organizers for giving me this opportunity. Well, before we get on to the various etiologies of adrenal Cushing across the lifespan, the adrenal Cushing even has a spectrum of clinical manifestation. It can present only as a mild subclinical Cushing in which the patients have no heart signs but non-specific features like obesity, hypertension, diabetes, and osteoporosis, or they may present as florid overt Cushing in which the patient develops catabolic features. The catabolic features of skin manifestation include mooning and plethora. As we can see, there is temporal fullness, and this mooning resolves after surgery. The plethora may not be visible in dark-skinned Indians, but definitely there is a change when we compare the photographs after surgery or in the patients or the prior photographs of the patients. The other catabolic manifestations are skin manifestations, wherein these patients can have broad, livid, depressed striae, which after surgery fade over. The catabolic manifestations of Cushing's can even involve bone and muscles, wherein this child with Cushing's has severe myopathy and muscle wasting that he is even wheelchair bound. And the severity of the bone disease is manifested in these x-rays, wherein we can see this child is having vertebral fractures because of Cushing's, and how when he is in remission, he is actually able to walk and move about, and there is a marked improvement in his muscle and bone strength. In patients in whom we suspect Cushing, thus clinically, after ruling out exogenous Cushing's, the causes of endogenous Cushing's can be considered as either ACTH dependent or ACTH independent. As we are concentrating on adrenal Cushing and ACTH independent pathology today, but we need to understand that the adrenal Cushing's are usually only 15% of patients with endogenous Cushing's. However, this percentage is much higher in children, where almost 65% of children younger than 7 years of age can have adrenal Cushing's as the diagnosis as compared to an ACTH dependent Cushing's. In adrenal Cushing's, again, the pathology can involve both the adrenal glands or it can be a unilateral pathology. In patients who have a unilateral pathology, the excess cortisol produced by the pathogenic adrenal will lead to suppression of ACTH and atrophy of the contralateral adrenal. In patients where we suspect Cushing's, the clinical diagnosis has to be established by a spectrum of tests, which can involve both quantitative and qualitative assessment of the cortisol axis. The urinary free cortisol is a 24-hour test which gives us a quantitative load of the amount of cortisol produced throughout the day. As it is a free cortisol, it is not affected by binding proteins. However, this test is cumbersome as it involves collection of 24 hours of urine. The qualitative tests involve the presence of altered circadian rhythm in cortisol, as we know that there is a suppression of cortisol in the evening and late night time, and hence a midnight cortisol as a serum cortisol or a salivary cortisol, if elevated, depicts an aberrant circadian rhythm. An overnight dexamethasone suppression or a low-dose dexamethasone suppression is another qualitative test of the cortisol axis, which assesses whether after giving a dexamethasone, the body is able to suppress its cortisol production or not. So in these patients with Cushing's who are florid, any test will be abnormal. But when we talk of adrenal Cushing, especially in adrenal incidentalomas where Cushing's is suspected, the dexamethasone suppression test has a higher value. It is mainly because these tests has been included in many studies, and hence the dexamethasone suppression test is a very useful test in Cushing's, in adrenal Cushing specifically. And as we know in the first talk of the day by Nalini Shah ma'am also, that the overnight dexamethasone suppression test is a highly sensitive and specific test. Coming to the history of this dexamethasone suppression test, it was established by Liddles way back in the 1960s, wherein the diagnosis of Cushing's was only driven as either being an adrenal tumor or an adrenal hyperplasia. What he realized was that when we give dexamethasone and monitor the urinary 17-hydroxycorticosteroid metabolites, all normal patients are able to suppress the urinary cortisols on a low dose on a dexamethasone suppression. But when he followed this up with a higher dose of dexamethasone, he realized that patients with Cushing's disease, that is those who have adrenal hyperplasias, which are ACTH dependent, are able to suppress their cortisols, whereas patients who have an adrenal tumor do not suppress the cortisols. This test is not only sensitive but also specific, as was depicted in a study which was done in our department, in which almost 1,000 patients with type 2 DM who did not have any clinical manifestations of Cushing's were screened with an overnight dexamethasone suppression test to diagnose the presence of subclinical Cushing's in these patients. We realized that after a 1 milligram overnight dexamethasone suppression test, 96% of the patients had a cortisol level of less than 1.8. And thus, this test is highly specific in establishing the diagnosis. And these patients who did not suppress on an overnight dexamethasone suppression were then subjected to a low dose dexamethasone suppression test over 2 days. And all these patients who had not suppressed previously now did. So we just concluded that the screening of patients with type 2 diabetes who do not have any clinical features with the use of overnight dexamethasone suppression is a very useful test. Right. In the diagnostic algorithm of Cushing syndrome, once we have established that there is a cortisol excess, the next step is to decide whether it is ACTH dependent or not. And the use ACTH as an assay becomes very useful in this distinguishing. When we analyzed a data of the last 100 patients with Cushing syndrome to decide how does ACTH behave in these different etiologies of Cushing's, we realized that in patients with adrenal Cushing's, when we consider the cutoff of 10 picogram per ml, there were still patients of adrenal Cushing's who did not have a ACTH of less than 10. In these patients, if we had gone on the basis of ACTH alone, we would have misdiagnosed these patients. And when we look into this cohort specifically, it is more of these adrenocortical carcinomas who had ACTH as high as 50 picogram per ml. And even many of these patients lied in the borderline zone of 10 to 20 picogram per ml. In our cohort in adrenal adenomas, almost all of them were below 20 picogram per ml. However, this data needs to be interpreted in the terms of clinical presentation. In a patient who has an overt Cushing, they will have a large quantitative cortisol production, and we expect that their ACTH will be suppressed. In our cohort, almost all of these patients with adrenal adenoma were those who had presented with overt Cushing, and then the test was done. It was not a patient who had presented with an incidentaloma and was then diagnosed with subjected to this ACTH test. In a patient with adrenal incidentalomas, who may just have a subclinical Cushing, their ACTH values may not be this suppressed. And when we look into these adrenocortical carcinomas, we realize that it is not even patients who have gross Cushingoid manifestations, as we can see clinical evidence of mooning, wherein we can see that their cortisol on overnight dexamethasone suppression are as high as 25 and 9, still had ACTH in the range of 30 to 50. But fortunately for us, these presentations had presented with an adrenal mass either as a complaint or had already been imaged for an adrenal mass, and we did not go on the wrong pathway of doing a pituitary imaging for these. But nonetheless, missing out an adrenocortical carcinoma in a patient in whom ACTH is elevated will be indeed a disaster. And hence, whenever we have a patient of a Cushing in whom the ACTH levels are not less than 10, we should at least get an ultrasound of the adrenals so that we are not missing out a large adrenocortical carcinoma sitting there. The other aspects of an ACTH test are that this test also depends on the laboratory platforms on which it is done. When we look at this is a sample report of an external quality assurance of an ACTH test. As we can see, when we look at the Siemens machine, when we have a sample of ACTH, when we compare it over all the machines, the mean value comes as 14.9. When this sample is run over Roche, the mean value comes as 9.59, whereas on a Liaison platform, the ACTH will be read as high as 32. And thus, there can be a negative or a positive bias, and this sample, which has an ACTH of only 14.9, will then go ahead in the direction of an adrenal ACTH dependent Cushing if we are reading on a Liaison platform, or an ACTH independent if we are reading on a Roche platform. And hence it is imperative that whenever we read this ACTH, especially those ACTH which are on the cusp or borderline, we should always repeat an ACTH, and also we should look into the platform which we are using. If we are using Liaison, we should be aware that the ACTH can be on the slightly higher side, and this platform has an inherent positive bias in the interpretation of ACTH. The another caveat in ACTH use is its lability. As we understand that in patients wherein the ACTH sample was stored and analyzed after a few hours, the value of ACTH which was measured decreased as a percentage of baseline at 48 hours to being almost zero. So if we collect a sample of ACTH today and we are reading it after 2 days, we can get a zero ACTH, and even a patient with a pituitary Cushing may be misdiagnosed as an adrenal Cushing. So what we need to understand is that ACTH is more stable in a plasma as compared to serum, and hence we should always use an EDTA bulb for collection. Again, a refrigerated sample will have a better stability as compared to a sample on a room temperature, and we should try to expedite the analysis of this ACTH test. As an alternative to ACTH, DHEAS is a test wherein, as we can see, it can be used as a marker for ACTH. ACTH has a half-life of 10 minutes, whereas DHEAS has a prolonged half-life of 10 to 16 hours. As in using an analogy of diabetes patients, ACTH can reflect a fasting sugar, whereas DHEAS is the HbA1c equivalent. As we can understand in this paper, where LCMS steroid profile of Cushing's was done, patients who had adrenal Cushing's had lower values of DHEAS, DHEA, and androstenedione, reflecting that the lower ACTH leading to lower adrenal androgen production, whereas patients with pituitary or ectopic Cushing's will have higher values. Nonetheless, this value for adrenals is of an adrenal adenoma. In patients who have adrenal Cushing's, they can be androgen secretory and can have higher DHEAS as well. So this caveat of using DHEAS as a marker for ACTH is only applicable in an adrenal adenoma and not an adrenal Cushing. Once we have used and understood the various caveats of using ACTH, we will then move on to anatomical imaging of the adrenals to localize the type of adrenal tumor. So as CT scan or MRI are modalities which can be used, and we routinely prefer to use CT scan to understand the anatomical pathology. The CT scan can give us the idea whether the pathology is unilateral or bilateral. By far, unilateral pathologies are more common than bilateral. So if we were to look at an adult with Cushing's, if approximately amongst the 15% of adrenal Cushing's, only less than 1% would have a bilateral pathology. And amongst the adrenal adenoma and carcinoma, 5% will end up with adrenal carcinoma and 10% with adrenal adenomas. But when this statistics is looked after in children, amongst the 65% of patients with adrenal Cushing's, 50% of children less than 7 years will actually have an adrenal carcinoma, and only 15% will have a benign diagnosis. So the CT scan can help us understand if there is a single or a bilateral pathology. And even among single pathologies, it will help us delineate whether it is a benign or a malignant pathology, as we understood in the talk on CT scan by Dr. Swati ma'am, as in how enhancement patterns, size, and the presence of necrosis or calcification can distinguish between adenomas and carcinomas. Bilateral pathologies can be either micronodular or macronodular, and by means of micronodules, we mean that the swelling, the tumors are less than 1 centimeter in size, and macronodular tumors are more than 1 centimeter in size. Coming to the spectrum of adrenal Cushing across the lifespan, as we can see, each different age group has an each different flavor of the etiology of adrenal Cushing's. The infancy and adult, in both the extremes of age, we can have presentation of adrenal cortical carcinoma. Coming to the childhood, PPNAD can present in childhood. This was the first case of PPNAD seen in our department. He is a 4-year-old child who presented with a 1-month history of weight gain, puffiness, hypertension. And as we can see on examination, he had lentigenes on his eyes. On biochemistry, he had clearly suppressed ACTH and a low dose dexamethasone suppression test, which was not suppressed. And on a Liddell's test, he had a paradoxical increase in the urinary cortisol after an HDDST. His imaging was done and the MRI adrenals were normal. And we should understand that in patients with PPNAD, the adrenals can actually be normal on imaging. We looked for echocardiography and associated thyroid and testes, which were normal in this patient, and thus he was diagnosed as PPNAD. He underwent surgery, and the gross specimen and the histopathology showed nodular hyperplasia with intervening areas which were atrophic, and he did not have any pigmentation. So PPNAD patients can also have nodules which are not pigmented. On follow-up, we can see that he was on hydrocortisone and fludrocortisone replacement, and he was growing well. This was a cohort of PPNAD patients which we had published recently, a childhood presentation of in which the youngest child of ours presented at 15 months, and they had varied spectrum from being a cyclical Cushing to overt Cushing and hirsutism as a presentation. One patient had a familial case. All of these patients had clearly suppressed ACTH, which was kind of expected because all of them are overt Cushing's. And on imaging, some patients had typical beaded appearance of adrenals, whereas some others had normal looking adrenals. The histopathology in 2 patients showed pigmented nodules, while in the remaining 3, the nodules were not pigmented. This could probably be because of the younger age of presentation of these patients. Not all patients had associated manifestations. 3 patients had only isolated PPNAD as presentation, whereas the remaining 3 had lentigenes as well. And the genetic analysis for these patients was also done, which was positive in the Prakar gene for 3 of these patients. The familial patient, when traced back, we came to know that there was an aunt who was almost 40-year-old who was just going on as being managed as diabetes and hypertension, and the consideration of adrenal Cushing in PPNAD was not even thought of until the index patient was diagnosed. Amongst these family, these 2 other patients underwent adrenalectomy, and these 2 patients just had lentigenes and are just being on follow-up. When we come to the pathophysiology of the PPNAD, the ACTH acts as a first messenger, which then through a G protein coupled receptor leads to an increase in cyclic AMP, which is the second messenger. And this cyclic AMP will then lead to increase in protein kinase A catalytic subunit, which is the third messenger. In these patients of PPNAD, the regulatory subunit is dysfunctional, and hence there is a marked increase in the catalytic unit, which then leads to a decrease in ACTH and decrease in cyclic AMP. When we come on to the adolescents who can manifest as adrenal adenoma, as is this young 17-year-old girl, her ACTH was less than 5 with an ODS of 19.3, which was clearly unsuppressed, and MRI showing a clean hypodense nodule of 2 centimeter, which was a cortisol secreting adenoma. She undergoes surgery, and we can see the marked difference in her clinical features made after the surgery. In these patients with adrenal adenoma, they have somatic mutations which can lead to formation of adenomas like the catenin mutation or mutations in the catalytic subunit of protein kinase A. When we come to adults, they can have adrenocortical carcinoma. For example, this patient who presents with Cushingoid features with gynecomastia and hypertension, which leads to an ultrasound and he ends up with a mass. And on investigation, he has a suppressed ACTH and ODS of 49 and an elevated estradiol, which has led to this gynecomastia. So he is a patient with cortisol and estradiol secreting adrenal mass who has a lesion confirmed on CT with no evidence of metastasis on the FDG PET scan. When we look into these patients with adrenal cortical carcinoma, according to the NSAID grading, they can have stage 1 to 4, in which the patients with stage 4 have distant metastasis, and unfortunately 40 to 50% of patients with adrenocortical carcinoma present with distant metastasis. And the survival also depends on the NSAT staging, wherein these and the eventual 5-year survival is almost 35% only in these patients. For management of these patients, surgery is the best chance for these patients. The patients who had an R0 complete resection had the best survival as patients as compared to patients who had no surgery. The surgery should be done in an experienced tertiary care center, respecting the oncological principles, and even the lymph node should be resected. This patient underwent surgery and was a adrenocortical carcinoma stage 3 as he had infiltration into the adjuvant tissue. And now he would thus require adjuvant therapy. He was given radiotherapy and subsequent follow-up, he was in remission. But then 12 months down the line, he started developing elevation of estradiol levels, and an FDG showed a node which then progressed to multiple metastasis and elevated ODS cortisol. He was then advised mitotane, which he was not affording, and uh, he underwent 3 cycles of chemotherapy. When it comes to the use of mitotane, there are certain caveats which we need to understand. Obviously, monitoring for safety of mitotane is inbuilt, that is, the monitoring of liver functions test and the complete blood counts to look for cytopenia should be done monthly and even 3 monthly. But the hormonal monitoring is what we as endocrinologists can enhance the care for these patients. Mitotane is an agent which will lead to decrease in adrenal hormones by increasing the cortisol binding globulin, by altering the metabolism of CYP3A4, as well as causing an adrenolytic effect and atrophy of the adrenals. Hence, these patients can undergo not only cortisol deficiency but also mineralocorticoid deficiency. And for monitoring of cortisol levels in these patients, a serum cortisol is of no use because they will have an elevated CBG. We need to actually do a urinary free cortisol in these patients. And even ACTH can be monitored and kept between 1 to 2 times the upper limit of normal on replacement. These patients may require monitoring of renin and electrolytes to understand for any evidence of evolving mineralocorticoid insufficiency, which can then be replaced. For monitoring of thyroid hormones, similarly, an elevated in thyroxine binding globulin can lead to falsely elevated total T4, and hence free T4 and TSH are required for monitoring. And similarly, these patients can have falsely elevated total testosterone levels, and the use of SHBG or free testosterone will enhance the value. And in these patients, the requirements of the replacement hormones can be as high as 120 milligram of hydrocortisone instead of the 15 to 20 milligram, which we give usually. They might even require as high as 300 micrograms of levothyroxine to keep the TSH in the normal range, and even 200 milligram weekly of testosterone to keep the free testosterone in normal range. And we should be aware that these high doses can be needed in these patients. In adrenocortical carcinomas, the pathology lies in chromosomal aberrations, wherein they can have increase in IGF-2 pathway, or they can have a mutations in the P53 or the beta-catenin pathway, which can lead to the development of these malignancies. When we come to the elderly age group, we have this young lady, this lady of 57-year-old who presents with weakness and on CT scan has bilateral nodules, which are hypodense with good washout, and she has a suppressed ACTH. Even on just monitoring, her values remain nearly the same. There is no increase in size, and the cortisol is just lingering around. In these patients with macronodular adrenal hyperplasia, they can be germline as well as somatic mutations in ARMC5 gene, as well as other genetic mutations like MEN1, fumarate hydratase can also be present. This is a 70-year-old who was incidentally detected to have an adrenal mass on imaging done for an urinary complaints. Although his ODS cortisol was only 3.45, he had elevated late night salivary or LDDS cortisol, and he also had osteoporosis on DEXA scan. So this elderly gentleman has an adenoma with a subclinical Cushing, and he was subjected to surgery and had a stormy post-operative course when he actually had herniation of bowel requiring surgery, ventilatory support, and wound dehiscence. Post-operatively, his histopathology showed an adrenal adenoma, and eventually he had a resolution of this cortisol excess. He had a loss of almost 8 kgs of weight, and we can see the marked difference in his clinical presentation. His antihypertensives and antidiabetics reduced. But when we talk of this etiology of subclinical hypercortisolism, the terminology is now gearing towards the use of autonomous or possible autonomous cortisol secretion. These patients can usually just present with these mild non-specific features, and on dexamethasone suppression, if they have an overnight dex suppressed cortisol of more than 5, they will be called as an autonomous cortisol. A dexamethasone suppression value of less than 1.8 rules it out, and between 1.8 to 5 will be labeled as possible autonomous cortisol secretion. These study showed that they can have some increase in all-cause and cardiovascular mortality as compared to patients with adenomas who do not secrete cortisol. However, due to small event size number, this data is not as representative. The management of these patients is mainly geared towards understanding the severity of cortisol excess. Patients with more than 5 of dex suppressed cortisol will be more warranting surgery rather than patients with with between 1.9 to 5. Similarly, the comorbidities dictate the management. A patient with subclinical autonomous cortisol secretion on surgery have improvement in antihypertensive and antidiabetics as in our case, but the improvement in cardiovascular mortality or bone manifestations has not yet been shown in studies. Thus, to conclude, patients with adrenal adenoma can present as overt manifestation who should and definitely will benefit from a laparoscopic surgery. Patients with autonomous or subclinical Cushing's will require individualized treatment based on the severity and comorbidities, and post-op steroid replacement is a must. In patients with adrenocortical carcinoma, the need for open surgery, especially in tumors more than 6 centimeters, adjuvant therapy therapies for stage 3 and stage 4 tumors and multidisciplinary care is the need of the day. Patients with Ppnads should undergo bilateral adrenalectomy and be on post-op lifelong steroid replacement. Not only that, the screening of their family members and the patients per se for other syndromic components is a must. In patients with macronodular hyperplasia, the treatment should be individualized. Thank you.